From the JAMA Network, this is JAMA Neurology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Neurology.
My name is Dr. Cynthia Armand, Associate Professor of Neurology at the Montefiore Medical Center in the Bronx, New York City, and JAMA Neurology web editor. Today, I'm here with two investigators discussing a topic called perceived chronic traumatic encephalopathy and suicidality in former professional football players. I'm excited to introduce Dr. Rachel Grashow, who's the Director of Epidemiological Research Initiatives at the Football Players Health Study at Harvard University. And I also have with me Dr. Aaron Baggish, who is a sports cardiologist as well as professor of medicine at Lausanne University Hospital in Switzerland and a senior faculty member at the Football Players Health Study at Harvard University. Dr. Grashow and Dr. Baggish, welcome to our podcast.
Thanks. We're so glad to be here.
Thank you. So nice to be with you.
This topic it's a hot topic. It's something that everyone discusses. And as a neurologist, especially when I talk to my patients who have children in sports and just seeing what's going on in the media and with football players in general, there's this question of what is happening with chronic traumatic encephalopathy and perceived chronic traumatic encephalopathy, and how do we prevent it? Do we not let our children play? And what if they are already in the game and they're older and they've been players for a very long time? Dr. Baggish, I'd love for you to start out with giving our audience a general baseline context of perceived chronic traumatic encephalopathy.
I'll start with just one upstream comment about the fact that sports and physical activity are among the most important ways to stay healthy across the age span, starting from very, very young years to as long as you're fortunate enough to be on this world. But nothing in life is without its complications, and indeed, contact sports do have a potential downside, and one that's received a lot of focus is this issue of chronic traumatic encephalopathy, or CTE, which, as I think we'll probably talk about, is a messy term. To be a little bit more specific, chronic traumatic encephalopathy neuropathic change refers to an autopsy finding. So again, it's a finding that can only be confirmed after someone has died, with a series of histopathologic features that have been linked to repetitive head injury. In the mainstream media, this very specific neuropathologic term has been interchangeably used simply with CTE to refer to not only what coroners find or pathologists find at the time of death, but also what people speculate may be symptoms and signs that living people that have been exposed to these sports may play. And it turns out that this paper is not trying to either confirm or refute any of that. What we're really looking at in this study is the concept of what it's like for a man who played football to simply believe that they have one of those problems, and what they look like and how they differentiate themselves from those who play but don't believe they have this problem.
Those are excellent points that you made. And I really like this study because whatever we get from the results, I think it would be a game changer in terms of individuals seeking help and getting therapy and ongoing treatment while they're alive, even after the fact. So I think that's wonderful. Dr. Grashow, take us into how your study was designed and the main points and outcomes that you were looking for.
So I just want to say that the motivation for this study began with one that we did a few years ago, where we saw that players from our cohort, and just to say, we have the largest cohort of living former players to date. But what we were finding in our living former players were them telling us that doctors and medical care providers had told them that they had CTE. And as you heard from Dr. Baggish, that actually really isn't possible because it's a postmortem diagnosis. So that raised flags for us that something was going on in our living players. And so when we saw that these players had been told that they had CTE, again, this concept of a neuropathological autopsy diagnosis, the next logical question for our group was how many of our cohort actually believe that they have it? One of our first questions was, how many believe that they have CTE? We also wanted to ask, what do those players have in common? We don't think that players are believing this at random. We think there are phenotypes and patterns that may lead players to believe this about themselves. So that was something we had the power to investigate with this really big group of people. And furthermore, the public perception of CTE, there's a linkage between suicide and CTE that comes up a lot in the public conversations, but that actually, as of yet, hasn't been shown scientifically with the rigor that it is discussed in the media. And so what we wanted to ask was, do we see a connection between suicidality and CTE beliefs in our cohort? And then again to ask, what do those players have in common? All in the service of saying, what can we offer to players now? What science and data-driven answers can we provide to players about their health that they can take action on now, since we still won't know whether they actually do have CTE until after they pass away? And to be clear, we can't know in this group how many of them will go on to get that CTE diagnosis after they pass, but we can talk about their beliefs of whether or not they have it.
What did the cohort look like in terms of demographics?
We have a total of 4,500 former players who have joined our study. For this particular group, 2,000 had filled out a survey that asked them these questions about CTE, about depression, about thoughts about self-harm. So in those 2,000 players, we look at things like their position. Do we have a diverse group of people? We want to have a lot of players of color. We want to have a diverse group by age, geography. And so our group is actually very diverse. I think we're fortunate and then can say something very broadly about former players, because we have players who didn't play a single game but were in a practice squad, and we have players who played more than 20 years.
Now, tell us about the different phenotypes that you looked at. And I would assume that those are part of the questions that you had asked with the cohort.
One of the first things we wanted to know is what percentage of the former players that answered these questions think they have CTE? And the answer to that is around 35%. So 1 in 3 of every former player that participated thought that they had CTE. And again, as I said, what we were really interested in was, what do these players have in common? What they shared was that conditions like sleep apnea, like hypertension, like high cholesterol, like depression, like low testosterone were overrepresented in this group. And we don't think that's an accident. What we think may be happening is that there's a lot of conditions that medicine is well aware cause cognitive symptoms, trouble with memory, trouble with concentration, mood lability. And what we think may be happening is that a lot of these players have these conditions that may lead them to think that CTE is a possibility for them because they're experiencing them. And so just to affirm that absolutely former players are experiencing cognitive symptoms, but we believe that they could be coming from a whole host of different conditions that we know are very prevalent in this group. And so what we found was that for the players who believed they had CTE, they were more likely to report cognitive symptoms, to have low testosterone, to have reported receiving more head hits when they actually played, that they were depressed, that they had mood lability or mood volatility, that they had chronic pain, and actually that they were younger. And that was the group more likely to tell us that they had CTE. Again, what we want to point out is that a lot of these conditions cause cognitive problems and cognitive symptoms like untreated sleep apnea and other conditions. So that was a key finding from this piece about the phenotype of the guys who thought they had CTE. We wanted to dig in further and ask, what is the prevalence of thoughts of suicidality and self-harm in these populations, both in the players who think they have CTE and the players who don't think they have CTE? When we did that, what we found was that among the men who didn't think they had CTE, we saw that 5% reported frequent thoughts of suicide or self-harm. When we looked at the players who told us they had CTE, 25%, or 1 in 4, expressed thoughts of suicide or self-harm. And we thought that this was really striking because basically you are 5 times more likely to be suicidal or have thoughts of self-harm if you think you have CTE.
That is very striking. When I think about these results, the topic, the keyword perceived is really important here because as a neurologist, there are so many neurological ailments where we make a clinical diagnosis for and individuals may or may not have it. And there's this perception that they have it because they're experiencing all these other symptoms that may just be sleep deprivation, depression, anxiety. And I think that may be unsettling for a lot of individuals, but especially in this case, that the perceived part of this is very interesting. And the suicidality portion is, like you said, pretty striking. I think that's eye-opening. And I think results like this make me as a practitioner, especially if I'm encountering someone like this, take seriously, as we should, putting these individuals with the proper therapy and treatments in order to battle this appropriately. I don't know. What do you think, Dr. Baggish, about these results?
Well, I think you brought up a very important point for the clinicians listening to this, and that is when they encounter a patient that has any concern about cognitive performance, cognitive difficulty, particularly if they're a patient that had exposure to repetitive head injury early in life, that CTE is a diagnosis of exclusion. They need to go through an exhaustive checklist focusing on really a multi-systems approach to all of the things that we know that are prevalent among anyone who's aging that can impact neurocognitive function. And at the end of that, there's still uncertainty about whether it's CTE, but we definitely don't want to attribute anything to CTE until we've crossed out the low-hanging fruit that can effectively be treated and in many cases make these players feel better and perform at a higher level in their daily lives.
I want to think that tackling it in such a way, even if at the end, after autopsy, it is shown that some of these individuals do have CTE, that they didn't die because of a suicide.
Yeah, I'll just add, if a patient or a former player walked into any of our offices with cognitive difficulties and there was nothing in their past medical history that had to do with football, you would probe for an exhaustive list of things and you would talk about depression, you would talk about anxiety, and you would probably go ahead and start treating those things.
Absolutely.
Right now, we have no idea if any of those things even relate to CTE, but there's no reason, if you think they may relate to CTE, not to treat them as you would in anyone else, with, in our experience, a lot of times very effective results. The other thing that's worth pointing out, and we couched this contextually in the beginning of the paper, is that when people receive a diagnosis that is thought to be progressive and incurable, and these are diagnoses that have nothing to do with CTE, diagnoses like Parkinson's disease, Huntington's disease, ALS, it's been shown without a shred of doubt that they're more likely to consider suicide and even oftentimes to take their own lives. And right now, CTE, whatever it is, falls into that category of something that people believe is progressive and doesn't have a cure. So this observation that those that perceive they have this problem follow the same trajectory as those that have gotten better understood neurologic diagnoses makes a lot of sense and really identifies these men who perceive themselves as being afflicted with CTE as being a high-risk group that we as clinicians should think about talking to and potentially intervening if they endorse suicidality.
Dr. Grashow?
I think that one of the pieces that we don't know as we untangle the effects of head injury, not just on a postmortem diagnosis, but on some of the conditions that occur over life, effects on hormonal function, effects on hypertension. As we uncover those things, what we don't know is what is the synergistic effect of head injury and having some of these conditions and having them untreated or poorly managed over time. And so what we want to sort of pose as a larger question is, yes, we cannot do anything about the head injury that these guys may have accrued when they played. But what if we go after, and what if they go after with their physicians, their hypertension, the sleep apnea, the obesity? It's an open question what the burden of cognitive symptoms will be and the concomitant fears about neurodegenerative disease will be if those things can be addressed as the player ages with their physicians.
What's next? What is upcoming in your research as a to be continued from the study, and what to follow up on and what to investigate secondarily?
One of the interesting data pieces embedded in this study was the very clear finding that exercise, routine physical activity, was actually protective against suicidality, even among men that perceived having a chronic incurable condition. And so one of the things we're very interested in, and obviously as a sports cardiologist, this is what I do on a daily basis, is understanding how physical activity and exercise can be used to either prevent or to treat not only people that perceive they have CTE, but many of the things that we know afflict people later in life. And so we're very interested in the physical activity patterns and the cardiorespiratory fitness patterns in this population specifically and how they translate into outcomes.
That's right. As we uncover more pieces of this pathway between football experiences and later life brain health, I think we want to look at physical activity, of course, and these other modifiable factors. What remains an open question is when we treat former players with head injury exposure, for, say, hypertension or sleep apnea, to see really how does their health improve over time? How does their outlook improve over time, their quality of life? So I think because we have this big group of living players, we can ask really exciting questions about the epidemiology of it all and what causes what, but dig deeper into interventions and put out interventional studies and other challenges to the football player community to address some of these issues and speak to their family members to encourage them to get some of these issues addressed.
Dr. Baggish and Dr. Grashow, thank you so much for enlightening our listeners on this topic and joining us on the podcast today.
Thank you very much. It's been a real pleasure to speak with you.
Thank you, Dr. Armand, for having us. We want to put out a big thank you to the former players who participated in our study.
Indeed, Dr. Armand, thank you very much for having us. Also, a very warm thank you to the remainder of the Football Players Health Study research team that includes a tremendously dedicated group of physicians, staff, and scientists. I might also add just a personal opinion about how the results of this study translate directly into the exam room for the clinicians listening to this. From my perspective, if a patient or a former player comes into your office and complains of cognitive difficulties, and they've had a history that may suggest they've had head injury in the past, before you accept that it's CTE, or maybe more importantly, before you allow them to believe that it's CTE, share with them the fact that that's the diagnosis of exclusion, and that a lot of other things need to be crossed off the list extensively and comprehensively before that can even be part of the discussion. Doing so will result in many people feeling a lot better and having otherwise undetected disease be the real problem when CTE is not the problem.
This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This is Dr. Cynthia Armand. Thank you for listening.